Good day, everybody. Thank you for joining today's Endo-ERN webinar entitled For a Prolonged Use of Antithyroid Drug in Children with Graves' Disease. The webinar of today will be given by Professor Julian Léger from Hôpital Universitaire Robert Debré in France. And Professor Léger is together with Dr. Edward Visser from the Erasmus University Medical Center, Rotterdam, the Netherlands, co-chairing Endo-ERN's thyroid expert group. Before we start, I would like to give you some webinar instructions. After the presentation, there will be the opportunity to ask questions. If you press the raise your hand button, we will unmute you and ask you to speak. Or you can submit your questions in the questions box. This webinar will be recorded for review purposes only, and it will be available at our Endo-ERN website afterwards. After the webinar, you will be asked to complete a short survey, and we would be grateful if you could complete it, so we can improve the quality of our webinars. For now, I wish you all a successful webinar, and Professor Léger, the floor is yours.
Thank you. Good afternoon. It's a pleasure for me to be here and to give this talk about the prolonged use of antithyroid drug in children with Graves' disease. As you know, I am a pediatric endocrinologist in Paris, and we did a lot of work on this rare disease in children. So, the next slide, no conflict of interest. Next, as you know, there is several causes of thyrotoxicosis in children, but the most frequent, representing more than 95%, is Graves' disease. The other hyperthyroid state in children could be due to autoimmune neonatal hyperthyroidism, thyroiditis, exogenous hyperthyroidism, autonomous functioning nodules due to somatic mutation in TSH receptor gene or GNAS, congenital activating mutation of a TSH receptor gene, McConnell-Bright syndrome, and less frequent selective pituitary resistance to thyroid hormone or TSH secreting pituitary tumors. The next, please. So, this disease is rare in childhood compared to the disease during adulthood, and you can see in this graph the distribution of the incidence throughout life. And as you can see, Graves' disease represents less than 5%. So the disease is related to the production of TSH receptor antibodies, and the pathogenesis is due to an interaction between the genetic background, environmental factors, and the immune system. As many other thyroid disease, it's more frequent in women, and the familial form corresponds to 20% of cases. And the next, please, about the symptom of hyperthyroidism. No, here you can see the distribution of incidence by age and sex in children. And again, as you can see, the female preponderance here in pink and male in gray. And you can also see that the incidence is increased with age and is higher after 10 years old compared to the incidence before. And I have to say that the patient under 5 years old represents almost 15% of cases in childhood. Next slide. Here is the main clinical manifestation of a disease with classic symptoms of hyperthyroidism, with goiter and tachycardia being the main symptom. Severe ophthalmopathy is rare in children, And in children, we can see the decline in the academic performance and an increase in height velocity with advanced bone age related to the duration of the disease, as you can see here in this graph. And as you know, hyperthyroidism affects cardiac and metabolic function, growth, and quality of life. And there may be some other autoimmune conditions. Next, please. And the biological manifestation are the undetectable serum TSH values, high serum FT4 and FT3 concentration, very highly variable depending on the severity of the disease, and the variable titers of serum TSH receptor antibodies. Next. So here are represented the most common association with other autoimmune or susceptibility disorders, such as type 1 diabetes, Hashimoto thyroiditis, Turner's Down-Digeorge syndrome, celiac disease, and less frequently than in adults, vitiligo, rheumatoid arthritis, and Addison disease. Next slide. So here is the potential adverse events of antithyroid drug therapy. And as you know, there are some minor side effects, which are mostly transient, such as cutaneous side effects, arthralgia, fever, transient granulocytopenia, and nausea and vomiting, abnormality of taste or smell, and arthritis. The same for carbimazole or metimazole or propyltiuracil. But there are also major side effects, agranulocytosis, liver failure, teratogenic effects, and with propyltiuracil, there are some toxic hepatitis and fulminant liver failure which has been described, and this treatment should be avoided in children due to these major side effects. Next slide. You can see here the result of a Japanese study which nicely shown that the adverse side effects of antithyroid drug therapy represent almost 20% of case, and most of these adverse events developed within the first 3 months after the start of treatment. The 2.7% of children who developed adverse events more than 2 years were induced by propyltiuracil. And you can see here that the cutaneous reaction represents were the most frequent adverse events, representing 18% of the case. And the major side effects, such as liver dysfunction and granulocytosis, represent less than 0.5%. The next slide. There is also a dose-related adverse events for the antithyroid drug, and it was nicely shown in this study. You can see that patient receiving a low-dose metimazole group has less adverse event than patients receiving high dose of this drug. And again, these adverse events was within 3 months of treatment initiation. Next slide. So there are 2 methods to treat patients with antithyroid drug. The block and replace and the dose titration. The block and replace is giving a high dose of antithyroid drug with the addition of levothyroxine treatment, and the dose titration is to adjust the dose of antithyroid drug to achieve euphyroidism without the need to propose levothyroxine treatment. So we know that adverse events are dose-related and that there is no evidence that patients under block and replace have more stable thyroid function. There is also some study which show that the prevalence of euthyroid are more often with antithyroid drug only versus block and replace. And more importantly, there is a similar remission rates with block and replace than dose titration. A systematic review demonstrated that the two regimens result in similar relapse rates in adults and in pediatric patients. And finally, the compliance, the adherence to treatment is more difficult with two drugs compared to only one drug. Next slide. Next slide, please. Next, yes. Alors, for the management, there is in childhood no evidence-based strategy because each therapeutic option, antithyroid drug, thyroidectomy, radioactive iodine, has associated complications. And most patients were initially treated at least 2 years with antithyroid drug, but there is a debate about the duration of antithyroid drug treatment. We know that fewer than 30% of children achieve lasting remission after about 2 years of treatment, and the current alternative treatments are proposed when there is a relapse after a course of antithyroid drug, lack of compliance, or antithyroid drug toxicity. Next slide. So what we learned from adult study, there are now some evidence to suggest that extending the medical treatment for at least 5 years is of benefit. Some patients prefer a prolonged treatment with a low dose of antithyroid drug. And we also know that the antithyroid drug treatment may be discontinued only if serum TSH receptor antibodies would decline below 1 unit per liter. And also we know the safety of long-term antithyroid drug treatment. So we also know that thyroid dysfunction during follow-up are more frequent in the radioactive iodine plus levothyroxine compared to the antithyroid drug treatment group, and also that long-term outcome on ophthalmopathy is more favorable in the low-dose methimazole group than the radioactive iodine group. So next slide. The question in adults and also in children is how to predict and possibly reduce the risk of relapse. We have to keep in mind that in adults, the age below 45 years old, high signs and high serum TSH receptor antibodies need a longer therapy, and probably there is a need for a more individual approach to treat the patients. Next slide. So we perform an observational prospective follow-up cohort study in France, included more than 150 children, and the protocol was that all patients were initially treated with antithyroid drug for 3 consecutive cycles of 2 years in case of relapse after discontinuation at the end of each cycle. And as expected, you can see here the results of the cumulative incidence of relapse after 2 years of treatment. In abscess, you have the months after discontinuation of antithyroid drug. And as you can see, 30% only of these patients were in remissions after 1 cycle of 2 years of treatment. Next slide, please. So a multivariable analysis shows that the risk of relapse was higher in non-Caucasian patients. You can see here that the risk of relapse was 2.5 higher than Caucasian patients, and the risk of relapse also increased with the increment of the FT4 at diagnosis, with the initial severity of a disease, and with the serum TSH receptor antibody increment. And conversely, the risk of relapse decreased with the increment of age and with the treatment duration. Next slide, please. And based on the finding of these results, we were able to generate a predictive score allowing 3 risk groups based on the variable we found. You can see here on the right how to construct the scores, and patients with a low risk group have the score below 3. Patients with an intermediate risk group has a score between 4 and 7, and patient with a high risk group has a score above 8. And you can see here that this interesting group had a risk of relapse almost at 100%. So there no chance to be in remission for this patient. The next slide, please. I will show you one example of a patient with a score at 8, young patient, non-Caucasian, very high serum FT4 at diagnosis and very high serum TSH receptor antibodies. So for this patient, no chance to be in remission after 2 years of medical treatment with a risk of relapse at 100%. So what have to do? Next slide, please. Definitive treatment should be considered earlier, but these patients are mostly very young, and because of theoretical risk of thyroid cancer, it may be prudent to avoid radioactive iodine therapy in children younger than 5 years old. So, next slide. I will show you the positive impact of the long-term antithyroid drug treatment on the outcome of children with grave disease. In this study, you remember that the protocol consists of a cycle of 2 years of treatment and to propose another cycle of 2 years if there is a relapse. And you can see the long-term effect of the treatment in this cohort of patients. And as you can see here, the cumulative incidence of remission increase with the duration of the treatment, being at increasing from 20 to 45 to 50% of remission after 8 to 10 years of treatment. Next slide, please. And the multivariable model show that 2 variables was associated with a chance to be in remission, having a personal history of autoimmunity or susceptibility factors, and less severe form of hyperthyroidism. The next slide. So in summary, for the prognostic risk on outcome in grave disease in childhood, there are some unfavorable variables such as biochemical severity, younger age, large goiter, non-Caucasian patient, non-compliance to antithyroid drug, and favorable variables such as presence of other autoimmune conditions, older age, and longer duration of antithyroid drug treatment. The next slide. We have also to keep in mind the clinical relevance of thyroid-stimulating autoantibodies in pediatric grave disease, as shown in this study. Serum TSH receptor antibodies level correlate well with disease severity and extrathyroidal manifestation of a disease. Hyperthyroid children with grave disease and grave orbitopathy showed markedly higher serum TSH receptor antibody levels compared to thyroidal grave disease only. And it has been shown that after a median of 3 years of treatment, the decrease of TSH receptor antibody levels was 70% in grave disease versus 20% in grave disease and grave orbitopathy. Next slide. The serum TSH receptor antibodies were also shown to be markers of remission. As you can see in this Italian study, the timing to normalize the serum TSH receptor antibodies, when it's normalized during the first year after beginning the antithyroid drug treatment, there is a more positive outcome versus when these antibodies normalize during the second or the third year of treatment. Next slide. Here is the result of a Japanese study showing again the cumulative remission rates which increase with the duration of antithyroid drug treatment. It was a retrospective study, but including a large number of patients, more than 1,000, and they show nicely show that the remission rates was at like in our study at 50%, represent 50% of the patient after 10 years of treatment, and maybe increasing a little thereafter. Next slide. Another more recent study, again showing the benefit of long-term of long metimazole therapy. It was a randomized trial, and after a median 22 months of metimazole therapy, half of the patients were randomly assigned to either continue low-dose metimazole or to discontinue the treatment. And the authors nicely show that hyperthyroidism was cured in 88 patients of the patient continuing low-dose metimazole group versus 33% of those who discontinued the metimazole treatment. And the result was demonstrated after 4 years of withdrawal of treatment. Next slide. Finally, it is the more recent study who also showed the benefit of long-term treatment, and you can see here in the graph that the cumulative remission rate increase with the duration of antithyroid drug treatment in this cohort of pediatric patients. Next slide. Here is the result of a systematic review. And again, you can see in abscess the treatment duration, and here the remission rate in percentage. And again, you can see that the remission rate increase with the treatment duration. Next slide. So coming to the hypothesis of the autoimmune aberration with the production of serum TSH receptor antibodies leading to hyperthyroidism, and hyperthyroidism by itself worsen the autoimmune aberration. And when this vicious cycle is broken by the treatment, rendering the patient euthyroid, a gradual remission may appear. It is a schematic diagram illustrating the hypothesis that a gradual remission of grave disease may be linked to maintenance in a euthyroid state for a long period of time, minimizing the thyroid autoimmunity. Next. However, the question is, how long should the treatment be continued to achieve remission? Probably between 3 to 10 years, depending on the severity of a disease and on the age. Next. And a continuous rather than cyclic antithyroid drug treatment should be proposed. Next slide. I would like also to show you a particular form of a disease. It's the T3 predominant grave disease. It is when there is a persisting TSH suppression and clinical signs of hyperthyroidism, elevated serum T3 level after serum T4 becomes normal or even low. It has been shown that type 1 and type 2 iodothyroidine dehydrogenase are overexpressed in the thyroid tissue, but the pathogenesis is still unclear, and it is a rare condition in adults. Next slide. We have shown it in children, but it represents 30% of the patient with grave disease, demonstrating T3 predominant grave disease. And the main characteristics at diagnosis between T3 predominant grave disease and the classic type of disease are higher titer level of serum TSH receptor antibodies at diagnosis, higher serum FT3 and FT4, larger goiter size. Next slide. And we also show that these patients with T3 predominant grave disease require more dosage of antithyroid drug during the treatment. You can see here patient with a T3 predominant grave disease in gray and patient with a classic form of a disease in white. And as you can see, during these 3 years of follow-up, you can see that a patient with T3 predominant grave disease require twice the dosage of antithyroid drug compared to the patient with a classic grave disease, and the dosage being almost at 1 milligram per kilo and per day compared to 0.3 after 1 year in patient with classic form of a disease. Next slide. So this patient require higher antithyroid drug dosage, and these findings highlight the need to measure serum FT3 levels in this patient, particularly those with persistent hyperthyroid symptoms with suppressed serum TSH levels. But whether these patients demonstrated a lower likelihood of remission in the long term remains still unknown. Next slide. So the other option to treat this patient, like in adults, are treatment with radioiodine or total thyroidectomy. We know the efficacy and the safety of radioiodine treatment. It's widely used in adolescent patients with no major late effects such as thyroid carcinoma and gonadal and hematological abnormalities. But this treatment should be avoided in very young children. It could be acceptable after 10 years, but better to propose this patient after puberty. And we have to know that it's not effective in case of very large goiter, and it should be avoided in case of severe ophthalmopathy. The other option is total thyroidectomy, which is also an effective treatment, but with a high complication rate, with recurrent laryngeal nerve paresis, hypoparathyroidism, mostly transient, but there is also some case of permanent hypoparathyroidism, hemorrhage, and scars. And this treatment should be performed by a high volume surgeon or when the child is too young for radioactive iodine treatment, or if there is a very large goiter and severe ophthalmopathy. Next slide. So a careful discussion with the parents and the child is required to determine the best choice of treatment between long-term antithyroid drug and more definitive options such as radioiodine treatment and thyroidectomy, and large prospective randomized trials with long-term quality of life assessment is still required to address this issue in children. Next slide. What's the future and next therapeutic reasons for treating this patient? Some hypotheses on the use of B lymphocyte immunomodulation. I will show you one result in a pediatric cohort study. Block immunoglobulin recycling, TSH receptor signaling using small molecular TSH receptor antagonist, or immunomodulatory TSH receptor peptides to influence the immune tolerance. Next slide. In children, there is only one exploratory trial in young patients with grave disease with rituximab. It has been published this year to explore whether rituximab, which is, as you know, a B lymphocyte depleting agent, suppressing humoral immunity, anti-CD20 monoclonal antibody, would increase remission rates when administered with a short course of antithyroid drug. Very short course, because it was only 1 year of antithyroid drug treatment. And it was an open label trial with 27 patients only, and rituximab administered at the beginning, and antithyroid drug treatment for 1 year, which was stopped after 1 year, and the primary outcome assessed at 24 months. And the authors show that the remission at 2 years was at 48%. But no conclusion could be driven, and a randomized trial is warranted to explore this treatment in patients with either pediatric patients with rare disease. Next slide. So, for the duration of a treatment in grave disease in children, medical treatment, what the take-home message? Metimazole or carbimazole is usually recommended as the initial treatment and is generally well tolerated. Undetectable serum TSH level and normal or low FT4, FT3 should be measured, because we have to know that T3 predominant grave disease require higher antithyroid drug dosage. Next, please. Remission is achieved in only less than 30% of children after a course of antithyroid drug treatment for about 2 years. but more prolonged antithyroid drug treatment may decrease relapse risk and increase the remission rate to up to 50%. Tell the parents the benefits and risk of antithyroid drugs are still uncertain and that they have the option of radical treatment after antithyroid drug treatment. Next slide. So here is an algorithm for the diagnosis and management of this patient. Treatment with antithyroid drug, carbimazole or metimazole, but never propylturacil again, for 3 to 10 years continuously, depending on initial severity and on the age. And after this continuous treatment, trial of medication, 2 possibilities, remission or recurrence of a disease. And if there is a recurrence, after a long-term antithyroid treatment, definitive treatment, better with radioiodine if possible, should be proposed, but the patient should receive levothyroxine treatment in the long term. And long-term surveillance, particularly because it's mostly women, and particularly during pregnancy, long-term surveillance is required in all patients. And if there is severe side effects of a drug or non-compliance with a drug, the definitive treatment should be proposed earlier. Next, please, next slide. So the current concepts on the management on grave disease in children, the importance of maintaining a thyroid state by antithyroid drug for long periods with prolonged continuous rather than consecutive course of treatment has been emphasized to minimize thyroid autoimmunity and the recurrence of a disease. The duration of antithyroid drug should be between 3 to 10 years, depending on the initial severity and on the age. And more importantly, the long-term therapy should be optimized by educational strategies to improve compliance to treatment. Next slide. What are the future results on the management? These results should be validated in other large cohort of patients to improve compliance with drug treatment through educational strategies, to improve our knowledge of the long-term effects of the various treatment options concerning potential morbidities, to study on the long term the quality of life, future pregnancy and outcome of the offspring, and a better understanding of the physiopathology should improve treatment options, remission rates, and patient management, and led to the identification of factors predicting the likelihood of remission. Next, and I think the last slide, here is the guidelines, the European Thyroid Association guidelines, which has been published this year in the European Thyroid Journal. And thank you for your attention. I think we have time now for some questions.
Yes, thank you very much, Julian. So we will now take some time for questions. So just a reminder, you can type your question in the question box, or you can raise your hand via the hand icon, and we will unmute you. So I will take a look if questions are coming up.
May I, in the meanwhile, start kicking off with a question while others are perhaps...
Of course.
So thanks very much, Julian, for this wonderful overview. I was quite struck by the relatively high odds ratio of the genetic background of people, the ethnicity, with non-Caucasians having a 2.5 times higher odds ratio. Do you have some more information? I mean, what backgrounds are behind these non-Caucasian people?
There are some reports on, I think it's a US reports on a higher incidence of a disease in African and in Asian population. And there are some hypotheses about their iodine status, but it's hypothesis only, and we don't have any data. In France, in our country, and I think in Europe, it's very difficult to have the precise ethnicity of a patient because it's for their ethnicity. So it is very difficult to study this aspect. I don't know if it is the case in Netherlands. Is it difficult to have studies about ethnicity?
Yeah, I think this is it is somewhat sensitive, although I believe in certain population cohorts we do have information on backgrounds, so that is possible, actually. Yeah. And also I was wondering, I don't know whether I spotted that correct, but in one of your slides you show that the presence of other autoimmune conditions had a favorable effect on. So can you, elaborate a bit on that? Which
at the
is
beginning,
a bit counterintuitive.
I also was surprised of this result, but I think that some patients with rare disease, and it has been demonstrated in adults, turn to thyroiditis. And so they became either in euthyroid states or in hypothyroid states. And there is an extension of the grave disease in this patient. It has not been very nicely studied in children, but it has been shown in adult cohorts.
Yeah, although you wonder, sometimes in the thyroiditis condition, you do see that the TSH receptor antibodies are just somewhat elevated. So you're also wondering, is this a true Graves or is this part of the thyroiditis? Yeah, so perhaps we can move to some questions. I do see a question.
Yes. Yeah. Can you see the question box, Edward?
Yes, it's quite small, but it's a question from Nina Sledner. And she, I assume this is she.
And there is a question about the other autoimmune condition, but I think we have speak about that.
No, there's a question on pediatricians treat patients up to 18 years of age. Do these recommendations also apply to the 15 to 18-year-olds? And what when they turn 18 and are transferred to adult department for follow-up? Do we risk that the treatment will be discontinued as the guidelines for adults are different? How should we handle it? So basically transition care as, being part of the second part of this question.
Yeah, it's a difficult question. You know, there is very few cohorts of pediatric patients with rare disease because, as you know, they grow, and after that we have to transfer the patient to adult service, and there is a loss of follow-up for this patient. So we couldn't, as a pediatrician, to have a long-term follow-up of this patient. And regarding the question on the management, there are now a lot of studies in grave disease in adults also show the benefits of long-term treatment. You know, 10 years or 20 years ago, it has been postulated that patients with grave disease in adults should have 1 or 1.5 year of antithyroid drug treatment. And after that, if there is a relapse, go to the radical treatment. And now it has been changed because some studies show the useful of the long-term antithyroid drug treatment with a very low dosage of antithyroid drug treatment. And the guidelines now were changed, and people are proposed a more prolonged antithyroid drug treatment in adults and now also in children. And I think that in children, the treatment should be very, very prolonged, between 5 to 10 years. And we have to construct some studies on long-term follow-up of these of a large cohort of children with rare disease to definitively demonstrate the usefulness of long-term treatments.
Thank you, Julianne. There's one other question by Pian T. Thanks for your excellent talk. May I know if there's concurrent other autoimmune conditions such as type 1 diabetes? Will this affect the natural history or the risk of relapse? Yeah.
So in our study, we have not studied T1 diabetes particularly, but we have a group of patients with associated autoimmune condition. There are some with type 1 diabetes, but there are other with other autoimmune condition. So I don't have the answer particularly for the group of associated condition, type 1 diabetes and grave disease. I have no specific answer, but I think it will be the same idea that this patient could have autoimmune thyroid disease and such as thyroiditis, and the disease will be transformed into thyroiditis instead of grave disease, and the serum TSH receptor antibodies decrease progressively.
Thanks very much, Julianne. I don't see any further questions in the chat.
No, and there's also no hands raised in the meantime. So, okay. Yes, it looks like we've covered all questions. Julianne or Edward, is there anything else you would like to cover before we wrap up?
Fine from my side. Thanks very much again, Julianne. Very, very clear. Nice to meet.
Yes. Thank you, Julianne, for your very valuable and excellent talk. And thank you all for joining today's webinar, which I'm going to close now. Oh, there's coming in another question just in time. We have time, I think. What is the suggested radioactive dose? How to count in terms of
weight? Yes.
Yeah.
Yes. Yes. The answer is yes. In terms of weight of the thyroid tissue, so the ultrasonography should give a very precise volume of the thyroid, and the radioactive dose treatment depends on the weight of the thyroid.
Okay. Well, thank you very much again, everybody, and well, enjoy the rest of your day. And please note that you will receive a very short survey, and we will be delighted if you can complete it. Thank you very much on behalf of Endo-ERN. Bye-bye.
Thank you. Bye-bye.